Senator Scott Jensen, who's also an M.D., a family physician. And we're going to him because he's raised his hand about some of the ways in which we're measuring deaths with COVID-19 that are upsetting to him because they're not based on science. And so it'll be really important to hear from him and what he has to share with us. Dr. Jensen, first of all, thank you for joining us. I wanted to reach out to you because I watched several programs where you raised the bell about concerns that there's this race to try and get the highest numbers possible for COVID-19, and that it's actually being incentivized by Medicare and the government. Can you share with people what your concern is and why you come forward?
Well, I tend to be a skeptic, and I think it was April 3rd, I received a communication from the State Department of Health, and in that, we were basically being advised as physicians as to how to correctly complete a death certificate if COVID-19 was involved directly or perhaps even presumptively or probably or peripherally involved. And when I read the document, I saw that there was a link for further information through the CDC. So I went there and I just shook my head and said, no, this is wrong. And so I raised it up the flagpole, if you will. And I reached out to 50 to 75 physicians that I'm in fairly close contact with. And I'm no spring chicken. So, I mean, I've been doing death certificates for some time, and I've never been coached or massaged in this way. So that was really what
you said you were coached and massaged to do what? To
put down COVID-19. I was coached and massaged to utilize COVID-19 as a factor in the causation of death, even if I hadn't checked a COVID-19 test, even if I hadn't had an interest in one. And right around that time, Dr. Birx from Washington, D.C. was saying that nobody's going to die with COVID-19. If they have it, they're dying of it. And that was about as silly a thing as I had heard, because if a person gets hit by a bus and over the first 2 hours of examination in an emergency room, we learn that both of their lungs are collapsed, but also some baseline laboratory works addressed the fact that there was a low hemoglobin, but also a COVID-19 test happened to be positive in the PCR form of it. It would be absolutely ridiculous to put down COVID-19. The patient died of a bus accident with both lungs being collapsed. In a similar fashion, if I've got a patient who's in hospice and they've indicated that they're not interested in aggressive measures, they want to have supportive comfort care and they want their dignity to be respected, and they've got end-stage emphysema and a congestive heart failure syndrome as well. And a week before they pass, they end up somehow getting exposed to someone who has COVID-19, who later on ends up being diagnosed with COVID-19. The underlying cause of death is end-stage emphysema and congestive heart failure. It is not COVID-19. If I'm going to put COVID-19 as a factor in that causation sequence, then it should be linked, be above one and below another, but it certainly wouldn't be the underlying cause of death, which really is the all-important thing that we put on a certificate of death.
It's interesting because when I was doing the research originally, I remember in late February, I was watching every day because I'm concerned that the death rate shot up 600% in one day. And I'm no epidemiologist, but that didn't make any sense. I'm talking about the world death rate. And then I dug in and finally found a little asterisk that said they changed the diagnostic procedure to no longer having to do a test. This is as late as February. And that's why the number of deaths shot through the roof, because anything they suspected as COVID, they listed as COVID. And then a few weeks ago, I know you know, and the CDC made it formal in the US that you don't need to do a test just if you suspect it. But there's actually, even as I understand from you, economic incentives by the hospitals, and some have been reclassified as COVID-19 deaths after the fact. And what is that a financial incentive, if you'll share with us?
Well, I have a background in coding, and so I've been asked to give lectures around the country at different times. So coding is something that's near and dear to me. So when I started seeing some of the massaging going on, I thought, okay, we need to do a little research. So I made some calls to hospital administrators, went on websites, checked out CMS or Medicare's information. And what I learned was that a DRG, or a diagnosis-related group, admission to the hospital for a Medicare patient for typical pneumonia would get paid somewhere around $4,600. But if it was put down as COVID-19 pneumonia, it would be $13,000. And if a ventilator happened to be used, it would be $39,000. I also knew that some hospital administrators knew, but may not want to confess in public, that their hospital was small enough that they probably would not receive the benefits of some of those, if you will, inflated payments. And so from that perspective, I started to do more digging. And what I learned was that this was indeed the case, that COVID-19 had been incentivized. And when I put that out on social media, I mean, frankly, all heck broke loose. People started to call me a conspiracy theorist, and it was just astonishing. And people didn't seem interested in facts. So at that point in time, I really took it on as a mission of mine that I was going to try to be about facts. I was going to try to be transparent, and I was going to try to help people connect the dots. And at that point in time, we saw shortly thereafter, we saw New York increase their numbers from 7,000 to 10,700 deaths overnight. We saw Pennsylvania subtract 250 deaths because the coroners pushed against them. We saw the Italian Department of Health go back and look at their causation sequence in their deaths and found that only really 12% of them stood up to the test of an actual sequence of causation in terms of death. So I think at that point in time, the horse was out of the barn. USA Today did a fact-checking thing on me and said, well, yeah, this doc from Minnesota, he evidently is right. His numbers are, they're standing true.
Wow. First of all, thank you for your courage and your commitment. I think some people's reaction probably is because we all know that, as it's already been put out, that all these doctors and nurses are putting themselves on the line. And so I think some people think maybe I don't know what they're thinking you're doing, but they're overreacting. And, people don't want to be confused with the facts, which is one of the reasons we wanted to do this program. As you look at the situation today with COVID-19, how do you think about it? How would you express to the general public what the level of concern should be? Because I know you know some of the latest statistics as well. Why? I guess the first question is, why would we? I understand. I don't think a doctor is going to put something down to try to make more money. But obviously, hospital administrators have to run that business, and hospitals right now are actually in tough shape. There's huge number of nurses and doctors being laid off because they set aside everything except COVID-19, as you know. But why is this rush in your mind to try to make these numbers as high as possible? Can you explain that to us? Because it doesn't seem to make sense to most of us.
I think it's a little bit like when we do our taxes and our accountant says, this expense, yeah, that could have been deductible. And they tell us what the scenario might be to make it deductible. And my accountant has frequently said, Scott, there's this line. On one side of it is aggressive, on the other side is fraudulent. We always want to be aggressive, but not fraudulent. Yeah. I certainly remember the first time a hospital administrative person came to me, and I was discharging a Medicare patient, and I had listed the diagnosis codes for the discharge summary as diarrhea and dehydration. And the major therapy that we provided during the hospitalization was intravenous fluids. There was no need for an antibiotic. But the hospital administrative clerk told me, well, if you switch those two diagnoses and put dehydration first, above diarrhea, we'll get paid more. And I said, oh, well, down the road, I remember discharging patients with congestive heart failure. But if I also identified, even though it didn't take a lot of work on my part, that they had a slightly low potassium, if I put the slightly low potassium, that argues for a greater index of severity. And then the hospital can sometimes get more dollars. They're not being fraudulent. They're just trying to maximize revenues. And I think corporations all over the country do that. So again, I was just trying to be transparent. I'm not trying to tell anybody that they shouldn't trust their doctors or their hospital administrators. I'm just saying, let's go into this with our eyes wide open.
Well, Senator, I can't thank you enough for taking the time. I know you've got to go make a vote, and I just wanted people to hear directly from you. And, you can read about someone, but you can feel your presence and your sincere love and caring for patients. And all you're trying to do is to keep us honest in this area so we don't overreact. And it sounds like so that people don't have excess fear. I mean, is that really your message? Is that what you're trying to help?
Tony, today I talk to patients every day. I talk to constituents. I mean, on the one hand, part of my life is in the trenches practicing primary care. And then I come down to the Capitol where I see this partisan battle for power. And the best way to power sometimes is to keep people frightened and then tell them who to blame. And after you've done enough of that, then sort of step up and raise your hand and say, but follow me, I'll take care of you. That's sort of a typical formula in the world of politics. We all sort of feel like we're suspended between, well, it's sort of like this. It's almost like we got in a time machine. And I don't know if I traveled back in time to a Rod Serling Twilight Zone episode, or if I traveled forward in time and I'm stuck in the Hunger Games and I'm in this, if you will, dystopic, futuristic place where government is slowly and insidiously encroaching on our lives. It's telling us what we'll do and whether or not we can open for business. And I think sometimes when these things happen, we don't recognize them at the time. It's when we looked at them through the retrospective scope. So I really think the crisis is pivoting. There's many people on this panel, if you will, that have done a wonderful job of laying out important statistical information, and you did as well. But I would submit that we're pivoting towards a time now where we have to ask ourselves our questions about who are we? What is our country? Are we losing personal liberties? If we're going to use contact tracing, what does that look like? Does that look like voluntary use of our phone? Or is it going to be involuntary? Are there going to be drones that swoop and watch us? We need to be very careful, because in the end, when we're all said and done, we're looking at a respiratory virus, a single-stranded RNA virus. We've dealt with these before. And we know that 40 to 50% of people who get it may not even know they had it. We know another 40, 50% that get it will skate through it. We know that we're probably going to, at the end of the day, end up somewhere between 1 out of 1,000 patients dying from it. I think we need to watch our personal liberties, but I also think we need to grow from this. We need to empower patients to say, you're up to the task. Don't turn over your care to the government or to a doctor. Get the second opinion. Feel good about it. If you have a doctor that doesn't want you being your own best champion, damn it, find another doctor, because we should not be threatened by the fact that you want to be in charge of your own health and that you might want a second opinion. And I think that's what's so inspiring about the panel that you put together here, Tony, is you're not political. You're just saying, let's have a conversation, America, because this is one of the most important conversations we might have in the next decade.
Well, Senator Jensen, Dr. Jensen, I really want to thank you. And coming from both a person in government and an MD, your courage and your willingness to bring this forward is priceless, and we thank you. I know you're going to go to make your votes there in the Senate, so thank you for joining us, and I'll look forward to following up with you.